I tell patients that they're only going to work in half of patients, no matter what medication it is. When we're looking at efficacy, PTNS has a higher efficacy for overactive bladder. And so the other thing is with medications, sometimes the medications work too well. And so we then put them into retention. And so our treatment options for overactive bladder, anything that's medication-based has the risk of causing retention and flipping them the other way. So to give them an option that's not an implant, that also can work, is really powerful.
Okay, thank you all so much for being here. I am really excited to talk about peripheral tibial nerve stimulation because as a resident, I actually don't get a lot of education on that. And so this is really exciting for me. Peripheral tibial nerve stimulation is essentially placing a tiny needle near the skin, near your ankle, to help treat the bladder. And to patients and people who aren't in the medical field, who don't know about peripheral tibial nerve stimulation, that can seem like magic or acupuncture. And so how do you talk about this? And, well, how does it work? How does peripheral tibial nerve stimulation work on the bladder?
So I'll go first, I guess. So no one really knows how it works. The thought process is that it's retrograde neuromodulation, basically. So the nerve for your tibial nerve actually goes up to the S2, S4 plexus there, which is the same plexus that innervates the bladder. So there is a thought that if you stimulate that nerve, or that if you maybe treat that nerve, that it can help your bladder to either calm down or to function better.
Absolutely. I mean, that's a pretty succinct way of describing it. I tell patients that, while it helps you to avoid the implanted version of sacral stimulation, while still being able to give you that therapy and to stimulate those nerves.
To piggyback off what y'all said so wonderfully, patients who are counseled about their options for overactive bladder, though PTNS falls kind of like at the wayside, there are plenty of patients who find it works for their lifestyles and they don't mind coming into the office once a week for a few weeks and their maintenance therapy. So I like that we have different options for different patients' lifestyles.
Absolutely.
That is actually a great segue into the next question, which is, the treatment for this requires patients come in weekly to your clinic. And a lot of patients work and have other obligations. And so how do you counsel patients, and how do patients usually fit this into their lives?
So it really depends because, there's millions of people, right? And so it's just another tool in the toolbox, and we have to make sure that the patient is a well-selected patient. So in my own practice, the people who I'm more likely to offer this to are those who work from home anyways.
Okay.
Those who don't, they don't want to implant, whether or not they just don't want something implanted to their body, or maybe they've had issues with implants or skin infections, or they have a lot of other comorbidities that would make us not want to increase risk. And this is just another good option for them if they can't get an invasive surgery like that. So it's just making sure that, and there's a lot of people who don't want medications. I know personally, daily medications doesn't work for my lifestyle, just remembering it. So to do something once a week versus on a daily basis really does help some patients, even though it takes time to come in.
To your point, because there are different patients, sometimes some patients need an introduction to the available therapy. And so maybe they have qualms about the implant for sacral neuromodulation. So proceeding with PTNS kind of opens that door. And so when they realize, okay, maybe I don't have once a week available, maybe I want something more long-term, that option is there for those patients.
Right. So again, to kind of go off that medication, you can take medication daily, and some people really are opposed to daily medication. Giving them the once a week option might work better for them. Maybe they're afraid of Botox, and they think coming in once every 3 months, they're afraid they have to undergo anesthesia instead of doing it in the office. And this right here, they're awake. They can kind of feel what's happening and let you know. And actually, there's something new on the market. So we actually do have an implantable percutaneous tibial nerve stimulator that, can do this not weekly, but can be done at home. So you don't have to come in weekly. You just come in, and if you do want it, if you're not afraid of a permanent implant or you don't want it in your back, then you can get it at the tibial area and have it implanted there, so you don't have to do the weekly treatments now.
There are so many things I want to talk about from what the discussion that just happened, but I want to go back just for our viewers. What we're talking about is when we talk about sacral neuromodulation, we're actually talking about an implant that goes directly on your back, and that may scare some folks, and people may have their reservations about putting something in their back. There is a risk of with any surgery, there's a risk of like infection, bleeding, and so, the peripheral tibial nerve stimulation is kind of as we've said, is a roundabout way of, not needing an implant, but you're still trying to stimulate those nerves versus the implant that goes directly in the back. And so that's kind of what we were getting at, is like, this is a way to kind of introduce folks to that neuromodulation without needing an implant. And so then we talked about medications. Like, some people don't want to take medications. And in our guidelines, in the SUFU guidelines, currently the way that we learn it is that, yes, it's nice to start with medications, but there actually isn't a specific, like, they have to start with medications and then they have to go to there's not really a specific guideline on that. A lot of this is shared decision making with patients. So I do want to talk about the implantable version, but I want to talk about that first. It's like, how do you counsel patients? We talked a lot about the side effects of each medication versus implant, but in somebody who just doesn't want medications, how do you talk about that? What does the insurance situation look like? Because I think that's
a whole different conversation.
That's like important here, right? Because we could do anything. We can offer anything to patients, but like, what does it actually look like for patients? And so that's kind of what I want to talk about, especially as a resident who will see this in practice all the time.
I remember when I first got out about 5.5 years ago, I was eager to introduce all these treatment plans to patients because overactive bladder is horribly undertreated, right?
Yeah.
And so I'd see patients who were just overwhelmed by their symptoms, and I would give them the whole lay of the land. You can start off with lifestyle changes. You can try medication. You can try, all the options that we're discussing. And then I realized that sometimes I just have to ask the patient, what would you want to do? What would you consider better in the next 3 months, 6 months, a year, And so having patients answer that up front has been so helpful and impactful in how I counsel them. And so, to the point of the patients who have already exhausted, pelvic floor physical therapy options, have already exhausted medications, right? Having the discussion with insurance companies, they're still kind of expecting patients to fail medication and try medications that may have side effects that can, I say, these side effects can be dry eye, dry mouth, constipation, increased risk for falls, cognitive decline. And, a lot of patients get scared that, why are we offering that? Or, when we offer a safer medication that may be more costly, I tell them up front, like, hey, this might be too expensive for you, but we're happy to negotiate with your insurance companies, because sometimes they may not be aware of what's safer for this particular patient. They're looking at an algorithm, and that may not be suitable for a patient who already has high blood pressure or is using a cane walker, So I just try to treat patients on an individual basis. Absolutely. And I think they appreciate that level of advocacy for them, and knowing that someone is trying to help them so that they can go out and socialize. They don't have to worry about planning their next restroom stop while engaging with friends,
Absolutely. And also, remember, I tell patients that when I'm going over all the options, that medicines are only going to work in half of patients, no matter what medication it is. And so when we're looking at efficacy, PTNS has a higher efficacy for overactive bladder. And so the other thing is, with medications, sometimes the medications work too well. And so we then put them into retention. And so our treatment options for overactive bladder, anything that's medication-based has the risk of causing retention and flipping them the other way. So especially with the fact that so many patients have underactive bladder, even though they have an overactive bladder, the tonicity, their strength of their contraction is not very strong, we are more likely to cause them retention and difficulty urinating with some of these medications and with bladder Botox.
Yeah.
So to give them an option that's not an implant,
Gotcha.
that also can work to at least not give them retention, not give them a UTI, is really powerful. So that's
Yeah.
another thing to think about. And I usually do urodynamics for patients
Mhm.
who I'm trying to, when I'm considering more procedural
Yeah.
interventions, because, with the procedural interventions, it's a little harder to undo those things.
Yeah. It's really interesting because from a provider perspective, we're like, yeah, we'll talk to the patient in whichever one they choose. But when you look at the cost on the other end, it's not the same.
Right.
Not all of these things are the same. So how have you experienced if like a patient comes in and says, I don't want to try medication, I want to try PTNS right off the bat. What are some obstacles to that for patients?
First obstacle is going to be coverage.
Yeah.
That is
Yeah.
number one.
Yeah.
I tell them that there is a 99.9% chance that this is going to be denied
Mm-hmm.
by your healthcare plan if you have not tried a medication or some kind of conservative treatment,
Gotcha.
such as pelvic floor feedback, biofeedback, or something, dietary modification, anything. It's likely not going to be approved without trying something.
Yeah.
And so I'm like, with the medications, you trial it, we see if you get any better, we see what kind of side effects you have, and with the new ones now, you know in 2 weeks. With the old medications, I'm from the olden days, the 1900s. We used to have to wait a minimum of 6 to 8 weeks, sometimes 12 weeks before we could see any kind of change in bladder function. Like I would push patients out a long time because I'm like, okay, they're not going to be happy. Need to give this medication time to work and got to kind of just keep going. With the olden medications, it used to be at least 3 months before we would see any kind of results or any kind of change. With these newer medications that you youngsters got, you get 2 weeks.
Okay.
2 weeks and they can see changes.
Okay.
So I'm like, that's pretty good with medication compared to what we used to have back in the day. So I say, most of the time I do ask them to try, or I ask them to try some kind of pelvic floor rehab or biofeedback.
Gotcha. It's funny that you say 1900s. I just saw a TikTok with a kid who asked his mom, Mommy, you were born in the thousands? And I was like, hold up, I'm born in the thousands? Anyways, I think that's a great segue. So let's say I'm a patient and I'm like, hey, I want to try PTNS. What does the treatment actually feel like? How do you counsel the patients? Like, you're going to come in. What does that treatment actually feel like sitting in the chair? Is it painful? Is it tingling? Like, what are the sensations? How do you know you're in the right spot?
Yeah, so I tell them that it's 12 weekly treatments. They're going to come in. I'm going to put a little acupuncture needle right into their ankle, little to no pain. And then they're going to sit in that room for about 30 minutes, and they can bring their laptop. They can bring their phones. They can do whatever they can do to distract themselves. They'll have their ankle propped up. I have a room set up where if I have multiple patients, they'd be able to all be in the same room together. So they can just kind of chat it up if they want to, so that they can get that therapy and continue with their lifestyle. Everybody's insurance is different. You have to have these conversations with patients to help them to recognize that insurance isn't standard for
Yeah.
everybody, and like you actually chose your insurance and
Yeah.
you chose the deductible, and so whatever my plan is, we're going to run up into the reality of whatever your insurance covers. So you might have copays when you come in for each of these 12 weekly treatments. Maybe
Yeah.
you don't. That's going to be based on your
Yeah.
insurance. And so I also encourage patients, I give them their codes,
Mm-hmm.
call your insurance and ask them exactly how much you're going to pay.
Gotcha.
I really try to get them to be involved in their own care. And I tell them, your insurance does not care if I call
Yeah.
to complain, because I'm not paying. That's
Yeah.
not my insurance. So
Yeah.
they're happy to deny me, but you're their actual customer. If you call and you
Yeah.
ask and say, who am I talking to? Let me get your name and
Yeah.
number and whatever it is, you're much more likely to
Yeah.
get approved for things.
And
so
empowering
I
patients
empower
to
them
really
be,
advocate for themselves. And do you
Exactly.
find that coverage can also be different in terms of how many sessions? Like, do you find that like some patients are only covered for 6 sessions and not the full 12, or is it usually?
You done insurance.
Yeah, it
more.
usually is. You're going to get the full 12.
Yeah,
You're,
okay.
you're usually, most insurance plans will cover the full 12. But a lot of people, again, are moving towards these high deductible plans, right?
Ah, yeah.
That's
So
true.
if you have a high deductible plan and this is your first major health
Absolutely.
expense, most likely you're going to be paying all of it out of pocket, right?
Mm.
Until you meet that deductible, and then your 80% co-insurance kicks in. So
Yeah.
you're still going to be responsible for 20% beyond that. So
Gotcha.
these treatments can be costly. I mean,
Yeah.
we're in the United States, and all of the R&D that's put into these treatments and the research dollars and everything that goes into it. So a lot of them, they require some cost.
Yeah.
I have a question. Are any of y'all using the PTNS sock therapy?
I have
Mhm.
seen a lot of different neuromodulation therapies that are coming out.
Mhm.
I haven't used any myself or any of my patients. I have patients who come in with like Amazon or
Mhm.
whatever saying, hey, what is this? And I'm like, it's probably based off the same
Right,
science.
right.
I'm one of the folks who, when PTNS did work, talk about TENS units at homes. And so whatever we can do to help patients to pay less money, because like we all have to deal with our own healthcare expenses as well. So I think that
Right.
I remind patients that we're patients too.
Yeah.
But it is kind of the reality of the situation that we're in.
Yeah.
And the reason I brought that up, because you can actually have the PTNS therapy at home.
Yeah.
And so instead of coming to the office, you can
Yeah.
lay up on your own sofa and do the treatments. And I think some insurance companies do cover that. So
Okay.
it ends up being an option.
Yeah.
Um,
I do want to circle back to that because I think that's like such an important advancement that we've had.
Yeah.
That's actually quite recent. Like a lot of these were only recently
Yeah.
FDA approved.
Mhm.
Even I guess like even some after I started residency, which was very recent. So coming back to the in-clinic experience. So I'm a patient, you put the needle in my ankle, I feel tingling on the sole of my feet. That's something that I have heard attendings do to make sure that they're in the right area, that they're actually stimulating the tibial nerve. What are other sensations or feelings that patients might have when you know you're actually in the right area?
Well, you don't want to feel pain. Like you
Okay.
should not feel pain.
Okay.
With that, because you might be too close to a bone or too
Mhm.
close to a different nerve that's there. So you should not feel pain. It should definitely be a tingle. And you should kind of feel your big toe do a little fan.
Did a little
yeah.
fan. Okay.
Mhm. Kind of similar to what we look for
Yeah.
with sacral neuromodulation, at least for the toes.
Mhm.
Okay. And then let's say I do the whole 12 weeks. What's next? It worked. What's next?
Maintenance therapy.
What does maintenance look like?
So honestly, so maintenance is supposed to be, was it every after 3 months, 4
yeah.
4 sessions.
And then after you do that, after those sessions there, then again, it's kind of based on, there's no set, like, okay, you
Yeah.
come in every 6 months for it. It's not like with Botox. Well, actually, it's kind of like with Botox. You come in when you feel
'Cause
like,
your
okay,
symptoms are-
your symptoms are
Exactly.
kind of getting, so you come into that maintenance phase there. And so it really is patient dependent how much of a response they had to their initial therapy when they had that, like especially if they were early responders versus late responders. We tell people that you probably won't notice any difference until at least that 6th treatment, so you really kind of got to hold on until you hit number 6. But if you're an early responder, maybe you will be able to last a little bit longer and you may not need as much maintenance. But yeah, at that 3-month mark, we kind of bring them back in for another 4 sessions and then we kind of see how they're doing. It's very important that you keep a bladder avoiding diary.
Mhm.
Got
You
it.
really have to keep avoiding diary. And the most important thing I tell my patients is I actually really have them do it on a weekend. Like, don't try to do this when you're working. Don't try to do this, when things are going on. Pick like a one weekend every month or when you're on these treatments to do your voiding diary where you can really focus. And I give all my patients a hat. I'm probably, because most of my patients are women. So I give them all a hat and I'm like, really measure,
Yeah.
urine, how much you're urinating, how much you're taking in, your fluids, and kind of really keep track of that. Because otherwise you may not know, kind of like when you're losing weight or gaining weight because
Right.
you see yourself every day, because you're going through it every day, you don't necessarily notice
Right.
the treatment. So you really do have to log it and keep that voiding diary.
Yeah.
Okay.
And it might help with coverage too. Your insurance company can see the progress and they'll be like, okay, we'll
Yeah.
continue to
That's a
support
good
this.
point. That's a
Yeah.
good point. So the summary of that is that maintenance therapy oftentimes needed. It depends on how the patient responds to the initial 12 weeks of weekly treatments, how much maintenance and how the interval of that maintenance looks. And usually when you show efficacy of the treatment, that can be covered by insurance, essentially.
Yeah.
I'm really excited about the at-home, PTNS therapies.
Yeah.
I know that Medtronic came out with one. A couple of other companies have come out, and they've recently gone through FDA approval in 2022
Yeah.
and beyond. And how has this like changed lives for patients in the field of, say, peripheral tibial nerve stimulation?
I think patients just appreciate the options.
Yeah.
When we talk about peripheral nerve evaluations and other modalities to try to improve their treatment, patients like the opportunity, like, let me try this first. You don't have to put anything inside of my body and I can see if it works for me. And then at the end of, 12 weeks, if they don't notice a big improvement, then they're more open-minded to consider other options that might actually be more effective for them. So I think it allows us to meet patients where they're at rather than kind of mandating what their treatment plan or having like a patriarchal type of, not patriarchal, I'm sorry, more paternalistic way of practicing medicine. So.
Yeah, absolutely. I always, like, one of my catchphrases is like, everybody has a bladder and genitals, so there's going to be something going on with it. And I also like to remind patients that OAB is a syndrome, and it's a very, very common one. So it's just, we need all the tools possible because all these different human beings all have bladders, and they're coming with different lives, different options, and different preferences, and also they are coming up with different conditions that are impacting their or causing their overactive bladder.
Yeah.
So being able to have an implanted option, because if somebody is living out rural, like I live in Georgia, like some of my patients are driving 2, 3, 4 hours to come and see me, and so realistically, to come once a week for 12 weeks, if you're driving that far, think about round trip, it really just doesn't make sense. So for those patients who, we, for some reason, we can't do this, the sacral neuromodulation in the back, there are people who have bone spurs going through their foramen, and there's a lot of reasons where you can't. You almost always have good tissue down in your ankle for that implanted PTNS. So it's really just allowing us to expand treatments to those areas where we couldn't before.
Yeah.
I guess maybe we should talk about who's not a good candidate, because I imagine patients
I
will
was
say,
just
"I
about
want
to
this."
ask. I was just about to ask. So, can a healthcare worker that is working 9 to 5 or like 7 a.m. to 7 p.m. every day, like walking around, can they do that? Like, can you walk around with this?
The implanted one, yes.
Yeah, the implanted
absolutely.
one. I just want to know, like, what can you do? What can't you do? Who is a great candidate?
Right. So I'm not sure about the sock. Like, I'm not sure if you can wear your sock to work and do that. I think you really do want to kind of be stationary for that 30 minutes and let the sock or whatever it is stimulate the nerve kind of uninterrupted. But I will say a little trick just for people out there who want to just test on their own. Sometimes you can try to tap your nerve on your own in the ankle. And sometimes you can try right on your backside, right in the cleft there. You can try and tickle that little area if you're having problems emptying your bladder, and just try to see if that helps you to stimulate and go. That's kind of the idea of what sacral neuromodulation is, or peripheral nerve stimulation would be, right? Those types of things. You can always try just to see if you can do it, but it's actually better with something dedicated to it as opposed to you trying to tap on it on your own.
I know patients who have swelling in their ankles are not great candidates. There's concerns that the therapy may not be as effective. Patients who have pacemakers are not great candidates because you don't want anything impeding that electrical activity. And maybe patients who, I guess, for the
peripheral
acupuncture,
vascular disease, definitely. If your toes are purple.
Or even a severe neuropathy.
Yes, right. And patients who probably can't come off of anticoagulation, that may not something that you want to do in your office necessarily with the bleeding risk.
Yeah. Well, I mean, that is pretty comprehensive as to kind of what the scope of PTNS currently looks like. Is there anything that you guys didn't think about before, but then as you started offering PTNS, like you're like, like this is something that I need to start incorporating a little bit more in the way I counsel patients or what I talk to patients about? Is there kind of like an aha moment that, especially for like younger urologists to kind of know beforehand?
Do y'all have OAB or overactive bladder navigators in your practice?
That sounds like a luxury I can't
I
afford.
wish.
I have a solo practice, so no, I am the OAB navigator. But honestly, it's the definitely, I think we're going to be more Gen Zers and Gen Xers who are very interested in it, and millennials who are very into regenerative and natural things. They don't want to put the medications in. They don't want metals implanted into their bodies.
Oh,
I think
interesting.
PTNS is, I think I can actually see it surging, where I don't think it's been utilized as much now because it really doesn't work. It has not traditionally worked for lifestyles, but now there's so much more work from home.
Absolutely.
There's so many more people who have much
Such a
more
great point.
modifiable lifestyle. So I can see it actually becoming more popular now.
Such a great point.
And I mean, at its core, it's acupuncture, right?
Yeah.
And so, I mean, that is the core. It is acupuncture. And we in Western medicine haven't necessarily embraced those type of techniques as much. But I just personally, my husband is interventional pain. And so, you know, his patients, he's doing TENS units, he's doing recommending acupuncture, chiropractors, like all of those modalities, because this is a multifactorial disease, right?
Yeah.
There could be lots of different things going on. And so we need to come at this from many different ways. You know, the old ways of thinking that there's just one pot for every lid. There might be a couple lids that fit your pot, right?
Yeah.
That you have to try and to get the right mix there.
Yeah.
Absolutely.
Well, thank you so much. That was amazing. And I hope that this was really educational for our viewers.
Absolutely.
Thank
Great
you.
conversation.
Thank you.
Yeah.